talk about high-grade spondylolisthesis. One of my friends proposed I should this take as a title, "Nothing disturbs your result more than true follow-up," because that's the background of my talk. I'm going to talk about children, adolescents and young adults on high grade, but only little about spondylolisthesis, spondyloptosis, sorry. This is what Ridwell has written. There's no right way to treat high-grade slips, and what I'm going to tell you does not mean that I believe that this is the only way to do this. What I'm going to tell you is based on learning, on doing things and then looking at them and then finding out whether it was worthwhile to do it or not. And if you look at the literature of high grades, you find all kinds of treatment proposals. On the left side, you see the most simple thing, that is bone in situ, and on the right side you see, I think that's the most bizarre I have seen for a high grade in a teenager, with a cage with the bolts through the vertebra into the sacrum and with pedicle screws. Okay, you have seen this picture, but this is not the same patient as the patient of Dr. Abraham, although the radiograph is absolutely the same. Okay, this 9-year-old girl, the school nurse was very clever and she detected a mild scoliosis. She's an athlete. She had no pain whatsoever. She has slight hamstring tightness and no neurology. But she had this scoliosis, as you can see here. 9 years old. What would you do? We have a standing radiograph and we have the clinical picture. Would you go for further investigations? Who would need flexion extension radiographs? Could you raise hands? Okay, what do you think you would learn, or why would you take them? What is the rationale for, in this case, for a flexion extension radiograph? Would it? I think we do many things, also myself, because we are interested to see what happens. But I think if we look at rationale for treatment or treatment decision, I think it doesn't help so much. MRI? Who would do an MRI? We get very nice pictures, we see the typical changes, but again, for myself, it would not influence what I'm doing. Okay, let's go further. Treatment options. Who would wait? She has no problems. She's doing her sports, she has a mild scoliosis, no radiating pain, no back pain. She's young and happy. Who would wait? Okay, who would try any kind of non-operative treatment? A brace? A brace? Or what kind? Brace and physio. What would you expect? What she has no pain. What would you expect from the therapy or from the brace? Make the muscle stronger with the brace and with exercises. Okay. Who would go for operative treatment? Okay. Anything else? Other treatment than what has been mentioned? No acupuncture or... Okay. Operative treatment. There are different options. But I think the most debate, operative treatment in this case means fusion. But what about reduction? Who would go for full reduction in such a case? Partial reduction? In situ fusion? Yes. Yes, you get it usually without doing very much in this case. I understand what you mean. Yes. Who would use instrumentation? Okay. Why do we operate? This is what Bradford has written. Prevent progression, relieve pain, improve function, and reverse the neurological deficit if there is any. And my claim, in the vast majority of cases, you can reach this goal by fusion in situ. And I will tell you why I believe that. It's usually said at the fifth goal we have to have is we have to realign the spine. We have to restore the alignment. And that's, of course, very, very important. And if we talk about alignment, we have to talk about global alignment and about local alignment. Globally, this girl, that's another patient, of course, is not very well aligned. Local alignment, we have seen, is also not good. And the claim is that we have to reduce to restore the global alignment. And we believed in that very, very strongly. And this was more than 20 years ago. We did this operation, we reduced, and we had happy patients. And we were criticized by people we thought who are conservative and said, what you are doing is unnecessary and you shouldn't do that. But we were, of course, convinced that what we are doing is right and we have to do that because of the alignment and so on and so on. All the same arguments. And then, of course, we were very proud. We had a series of patients and we wanted to show the world that what we have done is right. And this is, so far as I know, the first work where people tried really to compare reduction with in situ fusion. This was our first paper in 1993. And we investigated in these patients everything you can investigate in a spine patient. And this all has been done by outside observers. No one of our team was involved in this investigation or examination of the patient. And you see the conclusion. After 5 years mean follow-up, results were similar regarding pain, clinical neurology, signs, spine mobility, isokinetic muscle strength, maximal lifting capacity, and patient satisfaction. That means no difference whatsoever between those patients who had the big operation with front and back and metal and wrist as compared to those who had a simple in situ fusion without any metal. And I can tell you we were really disappointed. But we were not the only one. In 1997, this paper from Berlin, my friend Michael Muschig has done this and tried to compare anterior versus with and without reduction. And his conclusion, the results failed to show any differences in favor of either of the two techniques used, neither subjectively to the patient nor objectively by clinical examination. And later in 1999 from the United States, Molinari and co-workers, the results indicate that patients who had solid fusion, and that's the key, solid fusion, tend to be extremely satisfied regardless of the surgical technique used. And that's it. If you get it fused, wherever it is, if you get it fused and you have no complications, you have a good result. And although we did not believe that, but with time we started to believe, and there are other people. And this, we had another opportunity to look at the same patients, and that was now after about 15 years follow-up, the same group of patients as in our first paper with the same control population. And you look here at the figures. There are 11 patients in both groups. The mean age at operation was the same, male, female, male, because it was a matched control group. The slips were always the same. Follow-up time, almost 15 years. And then if you look at the Oswestry disability score in the reduction group is 7.2. And in the fusion in situ group is 1.6. It's even a little bit better. I would not claim that this is practically better. And you see they are all below 20 without except one. And this is another very important thing. We did the operation or the reduction not because of the slip. We did it because of the kyphosis, because we had been brought up by understanding then if you have this lumbosacral kyphosis, that's what you have to correct. And we looked at our patients who had residual kyphosis because they were not all 100% perfectly reduced. But there was no relation between residual lumbosacral kyphosis and outcome. And the same, there is a paper from the Bradford group by Serena Hu And she has a table. There are all the patients listed with all the data. And there's also one column with the residual kyphosis. And the same thing. They have patients who have still some 30 degrees of kyphosis, but they have an excellent outcome. It seems to be that even that does not matter too much. The word about fusion in situ. There's a very famous American spine surgeon who's not in the room, who's traveling around and telling people everyone should stop to do in situ fusions because in situ fusions are bad. He has seen so many bad results after in situ fusion. And what I believe is he has seen just such a case you see up here. 14-year-old boy had this kind of slip, and he had a fusion at that age of 14. And see what happens. 5 years later, the kyphosis is 27 degrees, and 15 years later, the kyphosis is 31 degrees. This is, of course, not fusion in situ. Fusion in situ means you fuse it and it stays where it is. This did not stay. This is an attempt of fusion, but this is not a fusion in situ. And what I mean is you have to fuse it and it has to stay. This is the same. The surgeon believed that he can get away with a simple posterolateral fusion in this girl. We saw her 2 years later. Then she had a spondylolisthesis and she had a peroneal weakness on both sides. This is not fusion in situ. The key is this. High-grade slip is a progressive kyphosis, and you have to understand this as a kyphosis, and therefore you have to provide anterior support. In one way or the other, you can do this from behind, you can do this from the front, but you need something in front because the sacrum is rounded and there's no support. Or you have to do a very, very long fusion, but that's maybe not the best way of doing it. That's what we are doing. We do combined fusions with bone anterior and posterolateral. From behind the Wiltse approach, we don't touch the midline. Although we have a very long incision, I call this minimally invasive surgery because we don't touch the midline. We go only through the muscles. Whether you use instrumentation or not, that's up to you. I think it's not necessary. It makes the operation bigger and more expensive and more dangerous. But of course, one can use it. And here you see this girl, 1 year after the operation, just the operation I told you. She's back to sports. You see it with her muscles. And this is how the x-rays looked 6 months after anterior and posterolateral fusion. After 3 months, the scoliosis was already much improved. I did not take long films anymore afterwards because she was straight. And that is after 2 years, you see posterolateral fusion, anterior fusion. And this is she after 4 years. I think this is not bad. This was the ideal case. If I see such a patient, I have to admit I'm happy. But look at this. This girl was at our outpatient clinics half a year or 5 months before this picture was taken. 5 months before, she was still straight. She had a high-grade slip, but she was straight. After 5 months, she looked like this. She had pain. She was almost unable to walk, and as you can see, she's terribly out of balance. And there's 44 degrees of kyphosis. And we did the same operation, anterior and posterolateral. And now look at the sagittal profile. If you look at the pictures preoperatively, and 6 weeks after the operation, she's almost back to balance. But she has still the scoliosis at 6 weeks. And of course I was worried about that, and therefore I put her in a scoliosis brace. And after 15 months she was overcorrected. That means possibly the scoliosis would have disappeared also without any treatment, but I wouldn't dare to do that. And you see at the far right side after 26 months, and you see her clinical development 6 weeks, 3 months, and 26 months. She's free of pain, she bends, and she is straight. Sagittal balance, that's what we touched on earlier, that this claim that you have to reduce to regain sagittal balance. This is a very interesting picture. If we look at the photograph, she's balanced. And if we look at the Radiograph, she's out of balance. Why? What's the difference? Where's the difference? Why does she stand in a different way? I tell you, the X-ray nurse forced her to straighten her knees. She's compensated here because she bends her knees. But in the X-ray department, she was told stand straight with straight knees, and therefore she has to bend forward. And you see her 3 months after this fusion. Anterior and posterolateral, no reduction. And therefore what we can state based on our figures and also on figures from other people, that reduction is not superior to fusion in situ, at least in this kind of cases. And that's what I said before already. There's no correlation between lumbosacral kyphosis and outcome. And I think this is our problem. I think everyone who's interested in sagittal profile and in spine in general should read this article by Stanyara, 86 in spine. It's not a huge material. It's something about 100 X-rays of normal people, measuring of lumbar lordosis. But there's very much sense in this article. And this picture is borrowed from this article. And that's the story of Procastus. Procastus was a Greek gangster. He had a guest house at a road crossing. And he had the strange idea that everyone should be of the same height. And therefore, when the guests came into his hotel, they were put on his bed. And those who were shorter as his bed, they were stretched. And those who were longer, they had their legs cut off. And of course, he took their money. And this is how the artist looks us as orthopedic surgeons. We have the Procastus complex. We have the strange idea that everyone has to look alike or the same. And in the best case, we also get some money for it. Okay, this is interesting. One of our work, when we sent it to Spine, it was published in Spine, but there was this comment by a very famous American surgeon. Are we so stubborn and arrogant that we cannot accept the possibility that what we feel has to be better on anatomic improvement is in fact not better when viewed from the patient's eyes? And I think that's what it's all about. We had this already in the morning session. We should look at it from the patient's eyes. We should look at it from the hopes of the patient, from the problems of the patient. We should solve the problem of the patient. That is important. Indication unlimited? No, there are cases you cannot treat in this way, at least in my feeling. This is a very, very high kyphosis with a very high slip. And what I do preoperatively is this. The patient is on the X-ray table. Of course, if they're painful, you need a person taking the legs and letting them down. You cannot let them fall down. Some are too painful. But this shows you two things. It shows you how mobile L5 is, and it shows you, if you do the anterior procedure, whether you can really get into the presacral disc space, which is sometimes quite tricky. The pillow, in fact, should be a little more distal. It should not be here where the lordosis is. It should be under the pelvis, because you want to rotate the pelvis anteriorly. And here you see, that's not the girl on the picture, but this is the same patient. You see the standing film on the left side, and you see the supine hyperextension. You see how mobile they are. But what happened here is that it does not reduce over the sacrum. That means even in this position, there's no contact between the lower end plate of L5 and the upper end plate of the sacrum. And in this case, of course, ordinary anterior fusion is not possible. In this case, you have to do something else. Maybe reduce it, or maybe the Bollmann technique. There are several ways of doing. This is an intraoperative hyperextension picture of the same patient. You see, this is in this case it is not recommended. Spondyloptosis is a different story. You see, it can be reduced and fixed. This is an older case. You have seen the pictures on the left already. This was this girl who had a posterolateral fusion, which did not solve the problem. And in this case, and this has been long, long ago, I did the posterior release. I took the fusion away and put her in a halo traction. And then I tried to fix it, and she was very skinny. I took the most flat instrumentation I had at that time and put anterior bone graft and a screw. And we ended up with a good result, but this was very difficult. The roots were so tight, and she had already, after this, when she came to us, she had already peroneal weakness on both sides. And the roots were so tight, I did not dare to pull it back. In our days, I would do something else, and that is, in this case, it's a very rare case where we removed the L5 vertebra. That is possible. We put L4 on top of the sacrum. It fused, but unfortunately this boy had a osteogenesis imperfecta. You see this from the long, pedicles there. And after that he started bending the sacrum. And that was, of course, bad. Another case of resection. This girl had been, it was a young lady now, but she had been operated as a teenager. The operation could not stop the progression, and she had now back pain and terrible alignment. Okay, and for everyone who likes to reduce, this is my recommendation. If you want to do it, go first and see someone else doing it. Do not try to learn it by yourself. I would never dare to reduce without seeing the roots all the time. We always did laminectomies, and maybe we even resected the pedicle. You have to see the L5 root. To fix it, you need anterior support. Total reduction has a higher risk of L5 root lesion than partial reduction, and use the instrumentation you are familiar with, and the goal is to achieve solid fusion. This is the conclusion. Fusion is strongly recommended in those cases. Uninstrumented combined in-situ fusion is the gold standard, and spondyloptosis requires individual solutions. Thank you very much. We have 10 minutes, and there was one case you wanted to discuss.